righty. Yeah, we'll go over that in a little bit, yes. All right, so we started talking about the temporal bone. We are, of course, getting material that is for exam 3. Yes, we should put that up. Thank you very much. There we go. Everybody can see it. Wednesday, you guys have your exam number 2, which we've already covered the material for that. Don't forget to bring your ID card so you know your student ID number. You will bubble it in. Most people did. And a number 2 pencil. We provide the Scantron. We'll have the sheet. You guys come in on Wednesday. As soon as you're done with the exam, you are free to go. And then when we come back on Monday, we'll continue with exam 3 material. Remember, exam 3 is right before spring break. So maybe you guys could actually relax a little on spring break, right? Also, a few people are still doing their bone eval tonight. And then don't forget, on Thursday or Friday, you guys have your what? Histology eval, right? So some of the material that you're studying for exam number 2 will actually be a good review because there's a lot of histology that we were going over. So that'll actually be like a dual study thing. So that's kind of helpful, at least at this point. And for those of you who have done your bone eval, this is a great review. And those that are about to take it, it's also a great review. So temporal bone. We talked about that a little bit last time. So the squamous portion, or the thin part, is the flat part of the bone. So this area here would be the squamosal part. The mandibular fossa is like an indentation. And you can see on this side, we'll put M for mandibular fossa, and that's where the mandible is coming into contact with the base of the skull, or with the temporal part of the bone. And this is on the inferior portion. So remember on your bone eval, if you didn't already take it, inferior versus interior view, what do you call it? Together versus disarticulated versus articulated, right? So read your slip of paper carefully. Make sure that you're looking at the correct bone. It's very easy to read through something and think you've got it. So just take a moment. You guys have time when you get your slip of paper and you have your book with you. So you can use that to help yourselves out. The petrous part, petrous is like rock, like you could think petrified rock. So petrous is the thick part. And you could see a petrous portion both on the outside and on the inside of the bone. So this would be the petrous part here, and then also the thin part in through there would be a petrous portion. So you can see it inferiorly as well as interiorly. And then we already talked about the mastoid region, which is the, I'll put MF for mandibular fossa on that other one, M for mastoid. And be sure when you're outlining things, you're outlining with your chenille stick, right? The whole bump, not just like, just touch it to the end of it. Now the sphenoid bone is considered the most complicated of the bones for the cranium. And so sphenoid, we think of it, it kind of looks like a butterfly shape when you look at the disarticulated bone, part of the cranial floor. And there are a lot of things to identify on it in lab. And here on the lecture part, we're not going into as much detail because you're kind of covering that in the lab portion. So you have optic canals, which basically is the whole length of the foramen. It's not just a hole. Canal implies that there's length to that foramen. And that's the openings for the optic nerves. And in lab later, we'll get to do a sheep brain dissection. And you'll get to see the actual optic nerve. So it'll make sense seeing how this would go through that area on the sphenoid bone. You also have the hypophyseal fossa, which is depression for the hypophysis or pituitary. So there's a lot to name around the sphenoid region in here, and this is the hypophyseal fossa, which is located in the sella turcica, which is horse's saddle. Okay, and when you guys see the hypophysis or the pituitary, it makes sense how this thing hangs down and how it gets kind of cupped and sits in this little saddle. Okay, then we have the ethmoid bone. And on the ethmoid bone, it's, we have a real one up there, but it's really hard to see some of the parts because it's such a delicate bone and it's been handled kind of roughly a few times, rough enough that it's broken off some of the pieces. And when you see, there's also a plastic model up there, and unfortunately the plastic model is kind of crude, so it doesn't give you all the details that you have with the real bone, and that's why we suggest looking at the Bouchain skull, where you guys could see the skull bones all disarticulated and shifted a bit, so you could actually see the cribiform plate and the perpendicular plate and things like that. So ethmoid bone is most of the area between the nasal cavity and the eye orbits. It's a very delicate bone. It has a crista galli, which is the upward projection in a triangular shape. I kind of think of it like a sail. So it's a triangular projection that attaches to the outer brain coverings. What do you guys think the outer brain covering is? The dura mater. And so it has two cribiform plates. And so if you're looking at the ethmoid bone, it's this area in here, and one cribiform plate on this side, one cribiform plate on the other side. And it has lots of holes in it, and why Sherry likens it to cribbage, which I don't really know how to play that game, but I know there's lots of holes and you put little stick things in it or something like that, right? So there you go. Let's see, what else? So the cribiform plate are openings that allow the olfactory neurons to pass into the nasal cavity. And one thing that you'll notice is like our olfactory bulbs are not as large as other animals, which makes sense that they would need to use some of their other senses to survive better. And we've kind of evolved to a point where we just kill everything else, so we don't have to survive it as well, right? So, you know. And then we have a perpendicular plate, which is located inferiorly, so below, forms part of the nasal septum inside. So nasally located, nasal cavity, and you can see it best on the sagittal section. And if we look at this picture down here, they're showing you the ethmoid bone is kind of the tannish color here, and you have the crista galli, which is that piece that sticks up like that. You have the cribiform plate and all the holes in this area. And then here is the perpendicular plate of the ethmoid bone where it forms part of the nasal septum. And then this they're saying septal cartilage. So you have your nasal bone, which is a tiny little bone there, the darker blue. And then this kind of periwinkle blue is just cartilage. So that's why you guys can move it around a lot and get bonked and hurts, right? But, okay, so let's look at the sutures. These sutures are immovable interlocking joints that connect the skull bones. And we pretty much consider them as not really movable, but you know, if you kind of squish your head together, you relieve headaches sometimes, or you can kind of feel like there's a little give. Most of that give you're feeling is your muscles and the soft tissue on the outside, but you can kind of feel your suture bones if you do like that palpation thing where they talked about feeling like the different areas in lab, where it said you could do that at home. So the coronal suture is separating the parietal and frontal bones, so think of coronal like a crown, okay? So it's the crown between parietal and frontal. You have the sagittal suture, which is between the parietals at the midline, so in between, going this way. You have lambdoidal, and if you look at the Greek letter lambda, that's why they called it lambdoidal, like that. And that is between the parietals and the occipital bones, so you're looking at the back here. And then you have squamous, or which is between the parietal and the temporal. So it's between the squamous portion of the temporal bone and the parietal. That's why they gave it that name. So those are all the things that we're talking about with the cranial bones, but now we're going to talk about the facial bones, okay? The facial bones, we have 14 of those. And we have, most of these are in pairs, but a couple of them are single bones. So our mandible is a single bone. It's the largest, strongest bone of the face, okay? It also holds your upper teeth, correct? And then sorry, I said mandible, lower teeth, correct? I was waiting for somebody to look at me like, that was weird. The lower teeth is on the mandible. Where are the upper teeth housed? The maxilla. The maxilla is actually you have two maxillary bones, okay? So maxillary, you have two of those. They're fused along the midline. That holds the upper teeth. And it's also the anterior portion of the hard palate. So you can see on this picture, and if you rub the tongue on the roof of your mouth, the two anterior thirds, the anterior two-thirds of the hard palate is that maxillary bone. The back third or so is the palatine bones, okay? So don't choke yourself trying to rub and feel that area or gag. But you can see on here, here's your maxilla, and you can see the upper teeth on those. So mandible, lower teeth, obviously, maxillary, upper teeth. And you also have two zygomatic bones. These help form your cheekbones, correct? One on each side. You have two nasal bones. These are tiny, but they form the bridge of the nose, so they're just on that top little portion there. Notice the teeny little guy there, right? You have two lacrimal bones, which are even smaller, but on the inside. These are about the size of a fingernail, and it's on the medial side of the eye orbit. So this is one of the bones that helps form the orbit area. You have the two palatine bones, so this is the posterior third of the hard palate. So that means it's more posterior, or you could say dorsal to the maxillary bone, correct? Because it's more back that way. Also, you have two inferior nasal concha. So these are the lateral walls of the nasal cavity, and you actually have a superior, middle, and inferior concha. And it's the inferior one that forms the lateral walls of the nasal cavity. And I don't see it on this picture because of the way they cut it, so it'd be more off, a little more lateral. That's why it's not on there. But if we go back up to the anterior view, let's go back here. All right, so this area here is your inferior nasal concha. Can you see what I'm pointing at there? Okay, so, and then you have the vomer bone, which you can also see from this view. That's right here. That'd be the vomer bone. I'm just writing the other one there. So vomer bone is the inferior part of the nasal septum. Okay, so if we go back, you can also see the vomer bone from the inferior view also. Okay. All right, and don't forget to check different views when you guys are studying some of the bones. It starts to make more sense as you get more familiar with it, where you can see like the sphenoid bone, you can see it laterally, you can see it anteriorly, you can see it interiorly, and then you also have a disarticulated bone. So, so play with that a little bit. So with the ENT would be checking the health, I guess, of the concha inside of the nasal cavity to make sure things are okay with that when you're having nasal problems. Part of the vomer bone, it's a nasal septum bone, so two bones make up the nasal septum, the vomer and the perpendicular plate of the ethmoid bone. They form the bony portion of the nasal septum, and anterior to that would be the septal cartilage. And what kind of cartilage do you think the septal cartilage is made out of? Hyaline cartilage. Yep, that's your knee-jerk reaction. If we say cartilage, think hyaline. And then if it's only in the ear or the epiglottis, do you think elastic? And then fibrocartilage for all of our cushioning and resistive forces and compression. We also have a hyoid bone. This does not articulate with any other bone. So if you feel along the sides of your mandible, go towards the back, and then you wiggle side to side, it feels kind of funky. That's wiggling your hyoid bone back and forth, okay? And you just have one of those, okay? And so it says it's a horseshoe-shaped bone attachment point for muscles of the tongue. It does not articulate with other bones of the body. It helps, though, in the movement of the larynx, so it helps a bit with speech and swallowing, okay? And All right, so let's see. And the larynx is attached inferiorly to the hyoid bone. Okay. So now we're going to talk about the vertebral column. And a lot of people will just call it the spine, but because this is an anatomy and a physiology class, we need to be a lot more specific with things that we're calling. So we're not going to just say spine. You need to either say spinal column, or you should say vertebral column. So we don't want to call it just the spine. Let's see. I'm sorry?
Just say vertebral, that's wrong. It's
yeah, vertebral column. Mm-hmm. And vertebrae would be B-R-A-E, usually is how it's spelled. So if you're saying vertebrae, vertebral. Mm-hmm. And so the vertebral column consists of 26 irregular bones. So consists of 26 irregular bones. They are designed to protect your spinal cord. When you guys get to do the sheep brain dissection, you will see how soft and mushy the brain is. And while we don't have the spinal cord attached to it, same thing with the spinal cord. So it makes sense that we need to have this armor to protect the most important part of the body. If your brain doesn't function, you can't sense things, you can't tell your body how to move or get away from danger or something like that, then you're kind of in big trouble, right? So it makes sense that we have to really protect something that is so sensitive, not just because it's a nerve, but nervous tissue, but that's partly why we need this strong armor there. So we have ligaments. There is an anterior and a posterior longitudinal ligament that runs the length of the column to help reinforce and stabilize. So sorry, this is kind of a little largish, isn't it? All right, so where the, you'll see a picture of it in a little bit, but basically the this ligament helps stabilize the vertebral column. Okay. The intervertebral discs, those are cartilage pads between the vertebra, and they actually go in between the vertebral body. So if you look at the body, also called the centrum, this area right here is the same shape as what the intervertebral disc looks like. Okay. In the intervertebral discs, you have two parts to it. One's called the annular fibro or annulus fibrosus, which is fibrocartilage, and it's like a collar around it. And this limits the expansion of the nucleus pulposus. Okay, so the nucleus pulposus is the center part, and again, we'll see a picture of this in a minute. This is partly why it's not always painful when somebody has a disc herniation. Not everybody knows they have one until it pushes out far enough out against the nerves that are exiting the spine, and that's when you start to have discomfort or other symptoms that go along with nerve problems. Okay, let's see, so nucleus pulposus is like a gelatinous center. So I kind of tell people that when they have first thing in the morning and you're really stiff, it's kind of like your disc is like an overfilled jelly donut, because while you've been sleeping at night, it gets more of the water and nutrition that is kind of being able to get back into the disc. Because all day long, when you're walking and doing all that compressive stuff, you're slowly pumping out a lot of that fluid. And remember, we have a lot of water in our discs, right, in our cartilage there. So when it's a little overfilled in the morning, once you kind of have moved around a little bit, you start to get a little more flexible, and you don't feel quite so stiff because you pumped off a little bit of that excess fluid. And so when you get a disc herniation, what do you think is actually herniating? Nucleus pulposus or the annulus fibrosus? It's the nucleus pulposus that's actually pushing out, and it's pushing out on the annular fibers there. But that's what's actually herniating, is the nucleus pulposus. So our intervertebral discs are great shock absorbers. Herniated discs can be painful, but the pain is not from that spot itself. The herniation is actually pushing against and compressing against the nerve. So the material that's herniating is the nucleus pulposus, which means the fibrocartilage collar wasn't what kind of CT? Is it dense regular or dense irregular? If it was dense irregular, it would be less likely to allow that herniation or a rent or a tear in it, because it would have been a little stronger for that kind of material. So this is actually dense regular, and that's what allows those tears sometimes to occur, and thus then the nucleus pulposus is what's herniating through those rents or tears, okay? And because of the placement of our anterior and posterior longitudinal ligaments, typically you're not going to have it bulge anteriorly and straight posteriorly, because those ligaments are another area that helps with stability and keeps it in place. So typically when people do get a herniation, most likely it's going to be a little what we call posterior lateral. So it goes more lateral out towards the back, not forward and not straight back typically, because of those extra ligaments, the ALL and PLL. So that would restrict the herniations. They tend to be posterior lateral, which is where the nerve roots come out. So and that's why you get compression in those areas. So let's look at the general structure of a vertebra. So you guys, we already talked about the body, also known as the centrum, and that's where the intervertebral disc will be hanging out. This vertebra here is what we would call a stereotypical or a typical thoracic spine vertebra. And there's certain features on it that tell us it's thoracic versus a cervical or lumbar vertebra. But some of the main features, as you guys have noticed when you've been studying cervical, thoracic, and lumbar, there's a lot of similarities. They just look a little different. And then there are a few things that are very unique about some of the bones in the cervical or some areas on the thoracic versus lumbar, okay? So basically, they all have a spinous process, which is a posterior projection there. We also have transverse processes that stick off to the side, okay? And we also have what forms the arch. So you have the body area here, and then the vertebral arch is along this area here. And together they form this hole, which is called the vertebral foramen, okay? We also have the pedicle, which I think of it as like a pedestal, so it kind of gives it support, okay? And we also have a superior articular process, which is the thing that's sticking up, and then it has a superior articulating facet, which is the smooth part. So you have both there. Those are two different things. The surface is the facet, the projection part of it is the process, and they go hand in hand. There's also an inferior articulating process and an inferior articulating facet. You just can't see it from this view because this is a superior view. Let's see, we also have, we said the vertebral foramen, that's where the spinal cord is going through, so you can see how this hole is completely surrounded by bone and protecting the delicate spinal cord. And then the nerves exit in between this bone and the one above, or this bone and the one below, okay? So we said the body or the centrum is disc-shaped, and it's for weight-bearing anterior portion. So when you guys looked at the lumbar vertebra, how big was the body or the centrum? It was bigger and thicker than the thoracic spine or than parts of the cervical spine, correct? Because that has to hold everything that's above there, all of the upper extremity and the torso. So it makes sense that the lower we went in the spine, the wider it had to become, so it could distribute those forces better. The vertebral arch is the posterior part or part of the structure. That's this angle that we made there. Vertebral foramen is the opening for the spinal cord formed by the body and the arch, and it makes up the whole. Pedicles are at the base of the arch, here and here, one on each side. And this is where the arch stands on the body, so you could think pedicle, pedestal, or you could think pedicle and pedicure, like your feet, whatever works for you, right? Processes are the bony projections, and we have a spinous process, which projects posteriorly, and we have one of those. And you have two transverse processes, which project laterally. So all vertebrae have articulating or articular surfaces, superior and inferior. And then you have the intervertebral foramina, which are the lateral openings between adjacent vertebrae, adjacent meaning the ones next to it. So this is the intervertebral foramen right here, and here's another one there. They've removed part of the bone so you can't see it, and here's the bottom of another one there. So that area there is the intervertebral foramina. Foramina is like foramen, just foramina is kind of like mini-me, so smaller foramen. This allows the passage of spinal nerves. So allows the passage of spinal nerves. Okay. So on this picture here, this ligament along the front of the bodies there is called the ALL, or anterior longitudinal ligament. And this part back here is the PLL, or posterior longitudinal ligament, because it's on the posterior side of the body. Okay, so that's what helped create the stability there. There are other ligaments on this picture that we're not discussing, so you don't need to worry about that. This area right here, this circular kind of area there, is the nucleus pulposus of the disc, because they removed a portion of the bone so you could see to the center of the disc there. And then these rings out here that you're seeing on the disc, annular, circular, so annulus fibrosus. Those are the annular part of the disc, of the intervertebral disc. And let's see, this would be, this region here would be the superior articulating process, and the top portion would be superior articulating facet. And the one that was on the other side here is the inferior articulating process and inferior articulating facet. Okay, and so those two come to get together, the facet joint, and it would be lined by what kind of cartilage? Hyaline, yes. That's like a gimme, right? All right. And let's see, I think that was good on there. And then you know this is your spinous process. You have your transverse processes there. You have your body of the vertebra there. If somebody had gotten, for example, like a compression fracture, typical time that might happen might be like in an auto accident, where all of a sudden the body goes forward and the front crushes down on the body there. It won't gain back. So right now you can kind of see that the body looks kind of squarish, right? But if somebody had a compression fracture, it ends up looking more wedge-like, like that. It compresses. So it's a type of fracture you don't usually see a line through it. It's usually where it's squished down the bone. And so it can be quite painful, but sometimes people don't always know they have it. You may also see this in older patients that have osteoporosis. And you may suspect it also in some of your older patients that are hunched forward and they can't straighten up. And you tell them, you know, get better posture, Grandpa, come on, you know, and they can't come up because it's been compressed forward. There's nothing to allow them to come up, and oftentimes it's painful if they do try to come up. And over the years it'll kind of heal, but they won't gain back that bone height. It'll still stay that way. So they're kind of stuck that way after that. And you can definitely see that on X-ray. Let's see. All right, so regions or divisions of curvatures. So basically, if you take a look, and let's talk about like if you have like a fetus, and so here's the head, and then they have kind of roundy, and then we have their hips, and we'll kind of put them like that. I didn't mean to put that last little funky line there. All right. Okay. And so we know for sure that while still in utero, so the baby hasn't been born yet, they have a primary curvature that's really obvious. And what area of the body do you think that curve is? Cervical, thoracic, lumbar, sacrum? Thoracic. So they have this major curve here for sure before they're born, and that's thoracic curve. They also have another one. Want to take a guess where that one is? Out of those 4 regions we named? Not lumbar, not cervical, sacrum, because it's going in the same direction. So this one will also go in this direction. Now, they have suspected, but for testing purposes, go with these occur after the child is born, okay? But they have been talking about how they can see a cervical curve in utero, but it's not really developed. The baby, most babies when they're born can't always hold their head up, and even if they can, it's not very long. They're pretty floppy looking, right? They look like one of those like floppy dolls on your dashboard or something, right? They're a bobblehead. That's what they kind of look like because they can't hold them up very well. So it's in the process of them learning to turn over, roll over, and look up when they are on their tummy that they start developing and strengthening the cervical curve. So that goes the opposite way, goes in this direction. And then as they are learning to sit up and hold their body weight up better, they'll form the lumbar curvature, which goes in the same direction as cervical. So I'm kind of drawing them over-exaggerated here so you can see how they have to go in opposite directions. Yes?
So I know you're supposed to hold a baby's neck, but I haven't held a baby.
Yeah.
Is it dangerous if you like?
It's probably not a great idea to let their head just flop over. Now, some babies have better strength and can hold their heads up pretty good right after they're born. They may have been, going like a full 40 weeks versus like a preemie baby that's been born a little early. They probably are going to take a little longer to reach some of those same milestones as the typical baby that gets around 38 to 40 weeks gestation. So, but you always kind of hold and protect the neck, and you'll watch some parents, they are more protective, and others, they kind of know their baby and let them bobble a little bit. And when they see the baby fatiguing, then they hold them a little better again. So it just kind of depends a little bit, but they probably might cry if their head flops over all of a sudden because it probably doesn't feel good to go thunk. But it's part of the learning process too. And you guys have kind of seen like toddlers when they're trying to learn to walk and you're trying to hold their hand and they're kind of pushing you away, or they keep trying to pull up on the couch. No matter how many times they fall over and hurt themselves, they keep trying, and then they finally get it and they like it. So we become lazy later when we're like, hold me all the time, because they know you will. So it just kind of depends, but yeah, you kind of protect them a little bit. So curvatures, we have some primary curves. That would be the thoracic is the main primary curve, and sacrum would also be considered a primary curve. Secondary curves would be ones that occur after you are born. So primary acquire in utero. Secondary would be after you are born and you have to acquire it then. So cervical, we have 7 neck vertebra. We typically would write C1 to C7. And of those 7 cervical vertebrae, we have 2 unique ones that don't look like any other bone in the body, C1 and C2. C1, the other name for that is atlas. So this is the bone directly below the occiput or the skull. And you could think of Atlas was carrying the world on his shoulders, right? So you can kind of think of his hands being like the area, the lateral masses that will come up to the occipital condyles and hold that up. So, so this area here is what's articulating with the occiput, okay? And there is no body. Nobody knows. See how there's no body there, right? There is no spinous process. So this is why it's atypical. It doesn't look like the other vertebra. The superior articulating process are mounted on lateral masses for articulation with the occipital condyles. So superior articular processes are mounted on the lateral masses, and they articulate with the occipital condyles. Okay, and they have other features that you guys have been learning in lab. You have an anterior protuberance, a posterior protuberance. It still has a transverse process, but it has a small hole here, and that's actually a hole for the vertebral artery to go through. Let's see, let's look at C2 before we talk more about that. And on C2, his name or other name, aka, is axis. And axis is what you can rotate around. So C1 rotates on C2, basically. So this also has a unique process here called an odontoid process. Odontoid. Don't you love these weird words, right? Process. Another name for that is the dens, D-E-N-S, dens. And that projects upward from the body into the C1 area, which is where C1 rotates. So projects upward from body into the vertebral foramen of C1 and allows rotation. So for example, some of you guys might remember Christopher Reeves, who played Superman in some of the original movies, and he was riding a horse and got thrown, and he broke C1, which allowed the odontoid process to move back against his spinal cord, and that's why he became a paraplegic, because the odontoid process sits right here where it protrudes up into the C1 area, and there's just a ligament that holds it against C1. There are some certain patients that you would have to watch out for. Sometimes people that have Down syndrome may not have that ligament very protective to hold that there. Also, no, it's not that so much as it's the actual ligament itself. But then also people that have, what's it called? Rheumatoid arthritis. That ligament can deteriorate with that. So there's just certain populations that you would be extra careful of, like if you're a chiropractor, you know. So, but they can do certain types of x-rays they call flexion extension x-rays, and they can see if it's a stable area and there's no movement, meaning that the ligament should be intact, because they can't see the ligament on x-ray, but they can see what's going on. If there's too much motion going on during a flexion or extension x-ray, then they could see if that would be safe or not to do that. So which allows nodding to kind of go back and forth like this. Occiput on C1, kind of like a rocking chair, right? And then being able to say, no, I don't want to eat that. That would be C1 on C2, right? With the rotation and stuff. All right, so, and still C2 has superior articulating facet. It would have an inferior articulating facet that you can't see there. It has the transverse process. It has the hole for the vertebral artery to go through. Now C2 does have a spinous process. And a lot of times in the cervical spine, they'll have what's called a bifid spinous process, bi meaning two. And that means as the spinous process comes out, it then projects a little laterally so that you'll see a little prong there. Can you see how that's kind of pronged on that one? Versus in thoracic and lumbar vertebra, it's just the single spinous process, no prong on it. And when I say single spinous process, I don't mean that cervicals have two spinous processes. It just prongs out at the end. So, If we look at the thoracic vertebra, we have 12 thoracic vertebrae, and like the typical vertebra we were looking at a minute ago, the difference is in the thoracic region. The reason I know that stereotypical one we were first talking about is thoracic is because it had some costal facets, costal meaning rib, that the cervical do not have a costal facet, and the lumbars do not have a costal facet. So that's how you can tell why that other one, if you go back and look at that picture, it had a couple facets there that we didn't talk about. So these guys have a transverse process sticking off to the side. That's one of the areas that a rib is going to come into contact with. It still has a superior articulating process with the superior articulating facet, an inferior articulating process with an inferior articulating facet. It still has a pedicle, which is the base. It still has a lamina. It still has the spinous process. And the kind of cool thing is if you look at the thoracic vertebra on an oblique angle, it kind of looks like a giraffe, right? If you look at the lumbar vertebra, the one below, this is also an oblique view. It looks kind of like a moose. The reason that they also say it kind of looks like a Scotty dog is there's actually a X-ray view that they will take where they can see if you have fractured the pedicle when they're looking for some. So if there's a break in the neck of the Scotty dog, so the Scotty dog, this is the ear, this is the snout. It looks a little different, and then the inferior articulating facet is like the front paw, and that's like the body. So that's where the Scotty dog analogy came from. It doesn't quite look like it in this view, but when you see oblique views on X-ray, you definitely see the Scotty dog look. And it looks more like a Scotty dog on X-ray than it does the moose, which we're looking at here. It looks more like a moose to me. So, so if you hear people talk about Scotty dogs, that's why. Let's see what else. So the thoracic vertebra, like the typical vertebra, but have costal facets for the ribs. Okay. And it also, the costal facets for the ribs are on the transverse process. It also has a demifacet, demi meaning like a smaller or half demilune, demifacet on the body for the ribs. They still have the lamina, everything else like we talked about. This is trying to show you the demifacet in here for the head of the rib. And if you guys were in lab and you held the rib up to the thoracic vertebra, you could see where there were facets on the rib that articulated with the facets on the vertebra. Let's see, in the lumbar region, okay, so this is the largest and strongest of the vertebra, and you typically will have 5 lumbar vertebrae. Occasionally, you might have a patient that has 6. The patient's not going to know they have 6 unless you take an X-ray of them, and it's an incidental finding usually. It doesn't mean that they hurt more or less than somebody that only has 5, but typically there is just 5. And hopefully you guys looked at some of the skeletons in the lab, and I think we had at least 2 that have 6 lumbar vertebrae. So that person may not be short like me or a short torso like me. They might have a longer torso potentially. I had a patient that came in once and he told me that he had fractured his back and has 6 vertebrae now. And I said, they wouldn't call it a 6th vertebra if you fractured it. I said, can you bring your x-rays in and we'll take a look? And he may have misinterpreted what the previous chiropractor or doctor had told him. I'm not sure. But I told him, I said, no, you have 6 fully formed lumbar vertebrae. And, you know, he did have low back pain, but it may not have been due to having the extra vertebra. So he did a lot of manual labor. So it was probably a lot of bending, lifting, twisting, heavy lifting, tires, things like that. So let's see. And same thing with the lumbar vertebra. You have all of the same things, superior articulating process, transverse processes. You'll notice they have the thicker but shorter spinous processes. Let's see what else. I already mentioned like a compression fracture, what that might look like. And let's see, if we look at the sacrum was 5 bones that end up fusing into one bone. It has one single superior articular process. This is to articulate with what? The L5 lumbar vertebra. Unless they have an L6, then I would say L6. But let's just go with L5 because that's the typical. And The auricular surface, auricle, think ear, that is on the ala. Ala means wing, so you can kind of see how this is one ala and here's the other ala, the wing of the, kind of looks like an alien-like thing, right? So on the other side, yep, that whole thing is a wing, and ala means wing. And on the other side of it, right. On the other side of it is the auricular surface. So they kind of are saying it looks ear-like, which I don't know that it looks like an ear, but so the auricular surface or surfaces on the ala articulate with the ilium of the pelvis. And that area we would call your sacroiliac joint, or for short, the SI joint. Okay. And again, that's on the posterior aspect. That's why you can't see it in this view, because we're on the anterior side of it. All right, let's see. Ala means wings. You also have ala on your nostrils, so when people flare their nostrils, they're flaring the ala of nostrils. Some people can do it better than others, I guess. You have, in this case, the apex of the sacrum is the pointy part down here, and this would be the base of the sacrum at the top. Yes?
So when somebody has 6 lumbar vertebrae,
Mm-hmm.
is it because the upper fused vertebra didn't fuse with the rest on the sacrum?
If that had happened where the, if S1 did not fuse with S2, and S1 still looked like a sacrum, they would still consider it a sacral vertebra. And sometimes people can have a remnant disc where you'll see that space in through here. When it's fused, we call it the transverse lines. But there is at least one pelvis that you could see a remnant disc was there. There was a little space there. Person wouldn't know that they even had that. It would be an incidental finding. Now, if they have a lumbar, if they're L5 or if they had an L6 and it looked more like the sacrum and there would be certain features that look more sacral-like than the lumbar vertebra, they would call it a sacralization. If they had an S1 that looked more like a lumbar, whether it fused or not, they would call it a lumbaralization. Or it might potentially be, but if they still see 5 segments, because you can still see 1, 2, 3, 4 segments, meaning you have 1, 2, 3, 4, 5 segments there, and you still had another extra vertebra there, then it wasn't S1 that had become that. But you can see all kinds of different variations in people that they would never know unless you took an x-ray. It's not something that you would feel it and go, oh, look, I think you have an extra lumbar down there that I was feeling in your low back. So, but the base is going to be the flat, broader portion or the top of the sacrum, and the apex is going to be the pointy, angled part at the bottom here. And you guys are used to thinking apex like apical surface, like with cells and stuff. So in this case, apex is the pointy part. And later on, when you guys get into 228, you're going to learn that the apex of the heart is actually pointing more downward, and that's the pointy part of the heart at the bottom of the ventricles, and the base of the heart is the wider, broader part, and it's at the top, like the sacrum. Let's see. Also, when we look at the coccyx, this is the little part right here at the bottom, which is between 3 to 5 fused bones, and we end up calling it one bone, and that's the tailbone. And if you feel at the very bottom, right before the anus, that's your tailbone. But I get people all the time that'll say, my tailbone hurts, and they really meant their low back, like the top of their sacrum. Big difference. That's why you always ask your patients, point to where it hurts, because what their version of what it is, and as you guys learn better terminology and being more specific, you'll realize you're not speaking the same language as the layperson, as the patient anymore. So that's why you learn all these details so that you can converse with other people and be very specific when procedures need to be done and things like that. But when you're talking to a patient and you start talking like that to them, you're going over their head and they have no idea what you're talking about. And they think you're not being very, having a good side manner, right? Because you're not speaking their language anymore. Which it's then a little tough sometimes to go back to like a seminar and everybody's being very technical and you feel like an idiot Because you got to remember all the technical terms for everything all of a sudden. It comes back, it really does. So we don't have to worry too much about the coccyx. Let's go back now to bony thorax, which is the thoracic cage. This includes the sternum, the ribs, and the thoracic vertebra. So when we say bony thorax, we're talking about a collection of bones that make up this area. So when we talk about the sternum, there is we considered, or other name for it would be breastbone, and it's the anterior midline of the thorax. You actually have a small upper portion called the manubrium, which you guys can see here. This is the manubrium. Okay, and then you have the sternum, which is the rest of this part of the bone here, like that. And this area right here between the manubrium and the sternum is called the sternal angle. And this is where the second rib articulates. Okay, that's where the second rib attaches. So if we say sternal angle where manubrium joins the sternal body and second rib attaches here. And if you guys were looking at the sternum on the skeletons, you would see that and be able to see where that second rib comes in. And how many ribs do you think you have? We have 12 pairs. And do men and women have the same number of ribs? What do you think?
Yes.
Maybe. Yes. No, I don't know. Yes. Men and women have the same number of ribs. So Sherry was talking about in her lecture, if you're going by like the biblical stories and they say Adam took one of his ribs out to make Eve, right? And so, but then what about his sons? But the sons then still had 12 ribs and the women all still had 12 ribs. So it's, stories that we learn from and we get information from. But it wasn't that he gave, so it didn't mean that Adam had 13 ribs and gave one, because then he'd have 13 on one side and only 12 on the other. That wouldn't work either. So, so yes, we have 12 ribs, men have 12 ribs, women have 12 ribs. For testing purposes, keep it that way. Although occasionally people will have a lumbar rib or a cervical rib, but it has nothing to do with that story, just so you know. In case you're still trying to make it work that way, that's okay. But you can see here, they're showing you how the ribs articulate with the vertebra. So you had a facet in this area here, you have a facet along there, and you had another facet along that area there. And you had ligaments that also help keep it articulating or against that surface, because this is a joint, and it would be lined by hyaline cartilage. And as we look at the rib cage here, most of you guys didn't realize until you noticed in lab that your first rib is all the way up here, right? And that your lower rib, if you really felt, is lower down than most of you guys thought, okay? So we call the true ribs vertebrosternal ribs. Those are the upper 7 ribs. And it means because it has a vertebral attachment and a sternal attachment, which are both bone. That's why they're called true ribs. So those are ribs 1 through 7. 1, 2, 3, 4, 5, 6, 7. And even though 7 looks like it has a really long cartilage area, it still attaches to the sternum there. So vertebrosternal, and that's the upper 7 ribs. Okay, so attached bone in the back and bone in the front. Then we have what we call the false ribs, which are the lower 5 pair. Make sure that looks like a 5. Okay, I still keep trying to make it look like a 6, not on purpose. There we go. 5, okay. And so we have vertebral chondral, which means it's going from the vertebra in the back to chondral, which means the cartilage to the rib above it. So that's 8, 9, and 10. All right. And then 11 and 12 are considered vertebral ribs, which is there's 11 and there's 12, and they don't attach to the ribs in the front by cartilage or anything. They're only attached by the vertebra. So that's why 11 and 12 are vertebral. And we had the next 3 pair were vertebral condyle, which was 8 through 10. All right. Another name for the vertebral ribs, or number 11 and 12, are floating ribs, because there was no anterior attachment. All right, so if we look at the appendicular skeleton, okay, so these are the things that we attach to the axis. So upper extremity attaches to the axis via the pectoral girdle, and the lower extremities attach to the axis via the pelvic girdle. So in the pectoral girdle, this is the shoulder girdle, holds the upper extremities to the axial skeleton. Only 2 bones are really what are holding this up there. So we have the clavicle and the scapula with the humerus. And so the clavicle and the scapula are the 2 bones that are attaching it to the axial skeleton. So, and the AC joint right there, that is where you're attaching the clavicle to the scapula, and the only attachment to the actual axial skeleton is the sternoclavicular joint. Sterno for sternum, clavicle for clavicular joint. Okay, and you guys, if you move your own shoulder around, okay, and you guys have looked at what the glenoid cavity looks like and the head of the humerus. So there's a lot of range of motion that we can do with our shoulder, right? Okay, you can't stick your leg bone over your head. At least I can't, and I'm not yoga friendly, so I'm not that flexible. That's a bigger ball and socket type joint, right? But the shoulder is also considered a ball and socket type joint, but you have a lot of range of motion. So you could see that the more range of motion you have, the easier it is to damage or get it hurt. Less protection, right? More range of motion, you compromise protection, okay? So 3 reasons why the upper extremity has such great mobility is only one small articulation point, the sternoclavicular joint, right? And then the scapula freely moves over the posterior thorax. So you could take your hand and kind of touch your scapula as you're moving it around, and it just glides over the ribs and the musculature back there. Okay, and then socket is shallow and poorly reinforced. So of the 3 fossas on the scapula, you have the supraspinous fossa, infraspinous fossa, and subscapular fossa. Which one of those 3 is anterior? Anterior. Think about the body. What's facing the forward part of the body? The ventral side. Subscapular fossa, yeah. And that is the reason why you guys are learning the bones and the fossas and the different articulations, as we've kind of said in lab, is because now next you're going to start learning about the muscles, and a lot of these spaces are named for the muscles that are attaching. So the subscapularis muscle is located on the subscapular fossa. Let's see. So it does not restrict movement is what happens, and that's why we have such great mobility. So it does not restrict movement. Okay. The clavicle, also known as the collarbone, you have a sternal end, which is the only attachment point to the axial skeleton, correct? And you have your acromial end, which is the lateral attachment, and it articulates with the acromion of the scapula. Thus, it's called the AC joint. People damage that area all the time. Scapula, especially if they do like baseball or softball, right? Scapula is also known as your shoulder blade. You have the glenoid cavity, which, as you guys saw, was pretty shallow. It's not a really deep socket, right? And that's for the head of the humerus. You also have the acromion, which is the lateral end of the scapular spine, right? And it's the process that articulates with the clavicle. Thus, we call it the AC joint. When we look at the upper limb, so another name for the arm So just from shoulder to elbow area, what's another name for that? The technical name? No? The technical name for that region? No? No? Brachium. Yes. Brachium. Because the lower arm is called the antebrachium. Here, let me erase and spell this right. There we go, brachium. So you have the head is proximal, meaning that it fits into the glenoid cavity. You have the greater tubercle, which is the lateral attachment site for rotator cuff muscle. You have the lesser tubercle, which is the medial attachment site for another rotator cuff muscle. You have the intertubercular sulcus, which is between the greater and lesser tubercle, also known as the bicipital groove. So what do you think fits in there? It's the long head tendon of the bicep muscle. You also have a deltoid tuberosity, which is a lateral attachment point for the deltoid muscle. The distal end has two condyles. The trochlea articulates with the ulna. And if you look at the arm, is the ulna medial or lateral if you put your body in the anatomical position? It's medial. And the capitulum articulates with the radius, which means that it should be lateral, correct? And then epicondyles, epi means above or upon, right? So epicondyles are points of muscle attachments above the condyle. So you got to be kind of specific when you're outlining epicondyle versus condyle, right? Because they are a different region on that bone. If we look at the forearm or the antebrachium, we have two bones that represent that. We have the radius and the ulna. So when you are, especially when you're thinking about the radius and the ulna, put your body in the anatomical position. Otherwise, it gets confusing because when you flip your thumb medially, which is another word for pronation, your bones cross. The radius and the ulna cross. And then it can throw you off with what you're talking about. So that's why the anatomist said, let's create this anatomical position, means put the body in this position, and that way you can see the bones lined up in this way, and you always have a reference point. So with the ulna, it's longer than the radius, and it forms most of the elbow, and it is medial in the anatomical position. Because of the crossover later when you are flipping the hand. So the olecranon process, I think that's a cool word, olecranon, like, I don't know, it's just, you guys should say these out loud, like in the middle of the test, olecranon! All right, so this is the pointy part of your elbow, okay? That would be the olecranon process. And it locks to prevent hyperextension, so you can't bend your arm backwards, if you will, too far. So, so this locks to prevent hyperextension. And it's because you have the olecranon fossa with the humerus. And if you guys put the ulna and put the olecranon and locked it into the humerus, you could see how they bend and unbend and how it couldn't go past a certain point, correct? The head is distal, okay, distal to the body, if you will, and it has or contains the styloid process. Which is the pointy part, right? And when we say it plays no role in hand movement, we are talking about supination and pronation. So it does not do this. Supination and pronation. So basically the radius is what allows supination and pronation. And if you're trying to remember what supination means, In order to eat with a spoon, like you scoop the soup up, so supination is how you remember it's turning the thumb outward. Pronation is turning it in, so it would spill everything if you pronate it, okay? So supination, thinks in order to eat a bowl of soup, you gotta twist your wrist up, flip it outward in order to supinate or eat. So all the olecranon or the ulna is doing is stabilizing the bone and that thing's attached to it, okay? The movement, the supination and pronation part is all due to which bone? The radius. So this is lateral in anatomical position. The head is proximal and it articulates with the capitulum. And there is an interosseous membrane, between, it's a ligament, and it's going between the radius and ulna, so B/T is between the radius and ulna. And you guys probably noticed when you were looking at the radius and ulna that it had a ridge on the shafts of the bone that were coming towards each other. So the medial side of the radius and the lateral side of the ulna had this ridge, and that's where the interosseous membrane is attaching to. Remember, anytime you have like ridges, spines, processes, things are attaching to them. And this basically just keeps things stable, especially as you are supinating and pronating, so it won't let things slide too much, and it's like a stabilizing ligament in between. It's like really flat and thin too. If we look at the hand, this is comprised of the wrist, palm, and fingers. So if we're looking at the wrist bones or carpus bones or carpal bones, we have 8 total carpus or carpal bones, 2 rows of 4 bones each. And you don't have to know the names for lecture, you do for the bone eval in lab. But for us, just know that there are 8 bones. Then you have the metacarpus or metacarpals, which are in the palm, and we number them 1 through 5. From the thumb side is being 1 to the pinky side or little finger is being 5. So thumb is 1 and little finger would be 5. And then you have the head is of the metacarpals is the distal part. So distal, more further away of the shaft, and the base is the more proximal part. And so when you make a fist, the head is the knuckle of that, which is the distal part of that bone. When we look at the phalanges, that's P-H-A-L, phalanges, those are your finger bones, and each digit has 3. You're going to have your proximal, middle, and distal, okay? Except digit number 1, which is for your thumb, you only have a proximal and a distal portion. So we don't have a middle on that one. And there's a lot to talk about on the coxal bone. Briefly, let's just say this to help anybody out before they go into their eval tonight. We have the pelvic girdle, aka hip bone, aka coxal bone, aka os coxa. All of those are synonyms. So if you see the term os coxa bone, if you see the term coxal bone, if you see the term pelvic girdle, if you see the term hip bone, they're all talking about one of those, a single, okay? That bone is made up of 3 bones that come together and fuse together. So you have the ilium, which is this top portion here, and if you put like a T through here, so you have the ilium here, you have the pubic bone there, and you have the ischium, I'll put ICH for the purpley colored part. Okay. And so that kind of helps you outline the T, because in that socket, or another word for that is acetabulum, okay, that's where those 3 bones converge. So you have all 3 bones in the acetabulum. So that's why it kind of looks like that. And this whole area is your acetabulum, okay? And just so that you know the difference between pelvic girdle, hip bone, coxal bone, os coxa as being one piece, one bone, right? Versus if you were to say the pelvis The pelvis is a structure. The pelvis is the two coxal bones and the sacrum. Okay? All right. So we're going to stop here. When we come back on next Monday, we'll continue with the pelvic girdle on and finish that and then move on to other stuff. We'll try to finish the bony section. And then also we will have Wednesday, don't forget, if you're in this class, it is the exam number 2 at 4 p.m., room 123. If you, wait, is this 123? Yes, thank you. If you are an internet student, then you would be doing either, you could take it in this class, you could take it in Sherry's class, which is Thursday, room 106 at 1 p.m. And, or if you are an internet student, you have to have signed up regardless of whether you're coming into the classroom to do it or one of the testing centers. And you have to take it anytime between Wednesday, 8 a.m. and Thursday. You have to be finished and it's turned in depending on the testing center hours at the latest 8 p.m. Right? Okay, so we're going to stop the recording here. Good luck and study hard on your exam. Woohoo!